Welcome back to part 2 of musculoskeletal chapter video. We're going to start with developmental dysplasia of the hip. So developmental dysplasia of the hip represents a wide number of anatomic abnormalities in which the femoral head and the acetabulum do not line up properly, or there may be abnormal growth. This includes dysplastic, subluxed, dislocated and dislocated hips. With dysplasia, it's characterized by a shallow, more vertical acetabulum socket with an immature hip and acetabulum. For subluxation, the hip is unstable and the head of the femur can slide in and out of the acetabulum. This condition typically occurs congenitally, or it can occur in infancy or earlier childhood, and it may be diagnosed many years after the newborn time. It can be impacted by physiological factors including maternal hormones, mechanical factors, if there was compression of the baby in utero, and any genetic factors. We just reviewed our risk factors on the previous slide, but physical exam, hip exams need to be included on all children up to the ages of 2. So there's different exams based on the age of the child, and the Barlow and Ortolani are done in the newborn, and the Klisick and the Galeazzi are done in older children. In older infants, you may note limited abduction of the hip or shortening of the thigh. There may be asymmetry of the inguinal or gluteal folds. In older children, there may be limited abduction and the affected hip and the shortening of the thigh, so there will be unequal leg lengths. You may notice lordosis or toe walking, and they may have more of a waddling gait or a limp. Ultrasound is a more superior test than x-rays for evaluating the cartilage structures, and is recommended when the infant is greater than after 4 to 6 weeks. Prior to this time, ultrasound can have a high incident of a false positive result. It helps to assess the relationship of the femur to the acetabulum. So the goal of management is to restore the articulation of the femur into the acetabulum. Most neonatal hip instability findings resolve by 6 to 8 weeks, but it's very important to refer and have close observation of these little ones. Some treatment options would include a Pavlik harness, a spica cast, and it's important to, if you are following with these kids, to help parents to manage their skin, cast care, car safety, and then follow up on these. Next, let's talk about leg calve Perth's disease, which is an avascular necrosis of the femoral head. The cause is unknown, but it's insufficient blood supply to the femoral head. The articular cartilage hypertrophies, and then the epiphyseal marrow becomes necrotic. The child becomes symptomatic when that epiphysis fractures. So some risk factors include gender, socioeconomic status, if there's been a history of an inguinal hernia or any GU abnormalities. History can be acute or chronic. The child can have an intermittent limp, persistent groin pain, or limited range of motion. On physical exam, you may note that antalgic gait with limited hip movement, so moving the leg so that it is not engaging the hip as much. There can be muscle spasms, atrophy of the gluteus, quadriceps, and the hamstrings, decreased abduction and internal rotation of the hip. Diagnostics and studies include x-rays, including the AP pelvis and a frog leg lateral view where the hips would be attempted to roll out. Differential diagnoses include infections, toxic synovitis, osteomyelitis, juvenile rheumatoid arthritis, and any cancers. These kids need to be referred to orthopedics. Treatment options treatment management will be the goal of keeping the femoral head in the acetabulum, and so that could be surgical or supportive. Complications include osteoarthritis and decreased use of the hip joint. The condition is not preventable, but early detection and treatment reduces its long-term complications. Let's next talk about slipped capital femoral epiphysis. The Salter-Harris classification is used to describe these, and this is a Salter-Harris type 1 fracture in the proximal femoral epiphysis. Stress around the hip causes a shear force to be applied to the growth plate. The fracture occurs in the hypertrophic area of the epiphyseal cartilage. Because the blood supply to the epiphysis crosses the weakened area, the epiphysis can be at increased risk for avascular necrosis. Typically, this can occur at the onset of puberty if there's an issue with weight, a skeletally immature boy with delayed puberty. Important to get a good history that may be vague regarding trauma, but there's noted pain in the hip, groin, thigh, or knees. The child may have limping or gait abnormalities. On physical exam, important to assess for obesity, delayed puberty, any pain in the groin, knee, or thigh. Note their limp if there's differences in their legs. Note for external rotation of the thigh. If the hip is flexed, you may know mild atrophy of the thigh and gluteal muscles, and there may be limited abduction and extension. Diagnostic studies include AP pelvis, frog leg, lateral and true lateral views. You're looking for a flattening of the epiphyseal prominence and any slippages that are noted. Management would be to orthopedic surgeon to put on crutches or in a wheelchair to prevent further slippage. There's a higher incidence of a contralateral slipped capital femoral epiphysis in the next 6 to 12 months for this child, and so support and monitoring through treatment is important. Complications, as we talked about, I believe earlier, could be vascular necrosis, and I believe we talked about, although it's not preventable, early identification is important to prevent complications. Next, let's talk about femoral anteversion, and it is a condition where the head and the neck of the femur are rotated at an increased angle anteriorly in relation to the femoral shaft, and the little one can walk with an in-toeing gait. In babies, that degree of anteversion is approximately 40 degrees, and it decreases with skeletal maturity. The gait is more noticeable in children 3 to 6 years of age and is maybe considered normal, but by 10 to 12 years of age, the normal angle of 10 to 15 degrees is seen. There may be a family history of this, and children often sit in the position of a W. On physical exam, we talked about in-toeing gait, internal rotation and external rotation is decreased, and the knees are more medially rotated. So there's a term called kissing patella, where the kneecaps touch more on the top versus the side. So it's not a harmful condition, no serious consequences. Observation is most usual the course of plan. If it is significant, then refer. Next, let's talk about genu varum, bowing of the legs. You can see pictures of that on figure 43.12. It can have a physiological or a developmental variation. It's considered normal until the age of 3. If the varus persists after approximately 30 months of age or the angle increases, it may represent Blount's disease, rickets, a tumor, a neurological problem, or an infection. It's important to get a family history on these kids and see if there was any parents or siblings that have had this. On physical exam, the tibial femoral angle is greater than 15 degrees. You may see internal tibial torsion. There may be lower extremity length discrepancies. And if the ankles are put together, then the knees may be separated by up to 4 to 5 inches. If this is seen, then that is cause for additional evaluation. There can also be joint laxity of the lateral collateral ligaments in older children. Typically, there's no treatment for physiological genu varum. If the deformity is worsening, referral to orthopedist, bracing is effective, and these kids can have complications later on with knee degeneration, so early identification is important. Let's next talk about the opposite condition, knock knee, which is genu valgum, and you can look on page 43, not 43, excuse me, figure 43.12 for some more pictures. It is more prominent in girls versus boys and is considered physiological until about 7 to 8 years of age. You want to get a good history, noting if there's been any progression of deformity, any risk factors, any joint pain, or stiff gait. On exam, the bilateral tibial femoral angle may be less than 15 degrees. They may have an awkward gait. The ankles may be distant when the knees are together, the opposite of what we talked about in genu varum. So deformities greater than 15 degrees and occurring after 6 years of age are unlikely to correct with growth and may require surgical intervention. And prevention is the most important thing. Next, we're going to talk about Osgood-Schlatters disease, which is a microtrauma in the patellodendon where it inserts into the tibial tuberosity. Diagnosis is made by history and your physical exam. These kids often are active in sports, track, soccer, football. They have increased pain with activity that's exacerbated with running, jumping, squatting, or stairs. The area may have focal swelling or heat or a point of tenderness, and they can reproduce the pain by doing similar type activities. Diagnostic studies are not needed unless there's concerns for some pathological finding. Management is self-limiting and symptom control. Avoid activities that cause the pain. Use ice or cold therapy for inflammation. It's important to do quad strengthening exercises when symptoms subside to strengthen the muscle group. NSAIDs have questionable benefits. A neoprene sleeve may be beneficial to stabilize the patella. One of the complications is persistent pain, and early management helps decrease the length of any issues. Next, let's talk about tibial torsion, which is twisting of the long bone along the axis. At birth, the tibias have a mean lateral rotation of 2.2 degrees and rotate laterally over time, with an adult mean lateral tibial rotation of about 23 degrees. I wanted to read that so I didn't botch that up. Tibial torsions describe rotations outside of the range of normal. These can be congenital, developmental, or acquired. The medial tibial torsion is the most common cause of in-toeing during the second year of life and is often noted around 6 to 12 months of age. In most cases, it's a physiological condition that results in how the baby was positioned in utero. 90% of these cases resolve on their own. These are kids that you will observe and monitor for that tibial version. If it becomes more significant, then refer to orthopedists. Special shoes are not effective. Let's talk real quickly about popliteal cyst, also known as Baker's cyst, are due to a collection of fluid in the knee joint that can be caused by herniation of the synovial membrane through the joint capsule. So, on exam, you may find a child that has swelling behind the knee. You can do an ultrasound to distinguish whether this is a fluid-filled cyst from a solid tumor. Differential diagnoses, lipoma, xanthoma, vascular tumor, or a fibrosarcoma. Management includes observation, rest, ice, NSAIDs. If continues or gets worse and is bothersome, a surgical incision may be required. We're going to talk just briefly about knee injuries. There is not a slide associated with this in this chapter, and I'm not doing a video on chapter 19, which talks about sports related injuries, but I encourage you to look on page 909. It's got a good classification of various types of knee injuries and conditions that are seen in little ones, especially related to sports. There, I want you to review the quadriceps contusions, the meniscal tear, the sprain of the ACL, sprains of the MCL, osteochondritis dissecans, and then dislocation of the patella. Just review those, and I think that you will be good for what you need to know for the exam. Let's next talk about pes planus, which is being flat-footed. Usually resolves by 2 to 3 years. Um, it can persist into adolescence and is usually associated with the familial laxity of that ligament. It can be associated with Marfan's or Down syndrome. Its onset is usually with weight bearing. It can be painless and asymptomatic. So it's where the arch disappears when standing. Range of motion is considered normal in a flexible flat foot. Management is referred to orthopedist for orthotics if symptomatic. You can place removable longitudinal arch supports in that will help provide more support in the arch area, and passive stretching if the Achilles tendon, if tight, may be needed. There can be normal variations of this and should not be concerning unless there's pain or rigidity. Next, we're going to talk about metatarsus adductus. You can see a figure of this on 43.14, and that's adduction of the forefoot in relation to the hind foot. The most common cause of this is intrauterine molding, and the deformity is usually bilateral in about 50% of the cases. There may be a family history. On physical exam, you may note that the forefoot is adducted and the midfoot and the hind foot are normal. It's important to grasp the heel of the foot and try to abduct the foot to see if it's flexible. Imaging is not needed. If the child has a flexible foot, then it's important that the parents try to stretch the foot with each diaper change. If the foot is non-flexible, then to refer to an orthopedist, and they may need serial casting. So the next thing we're going to talk about is in-toeing and out-toeing, and that's the degree of rotation and the source of deformity. The causes of in-toeing are usually physiologic and are related to age and resolve as the child grows. There's a good table on page 912, typical causes of in-toeing and out-toeing rotational problems. It talks about what the possible diagnosis would be, what you will find on your physical exam, and then the age when you will typically see this. So you may or may not see much of this in practice, but if you do see a child come in with in-toeing or out-toeing, or a parent with concern for it, it's important to at least know what some general ages are and what to look for in the foot. Each type of condition will determine what the treatment plan will be. Okay, let's talk about toe walking, and that's persistently walking on the toes. Often is associated with a neurological problem such as CP. Some young children, though, stand on their toes until they're established their heel-toe pattern, and that's usually within the first 6 months of walking. If you have a child that's just toe walking on one side, that may be associated with a shorter leg. It's important to assess for when this happened, the severity, if there's any neurological history. Were they using a walker or a jumper when they were infant? Look at the shoe wear, assess for a tight heel cord. Important to conduct a neurological exam and be sure and measure leg lengths and measurements of hip lengths. Management is going to depend on the etiology, and orthopedic referrals may be needed for tight heel cords or unequal legs or hip problems. All right, let's talk leg aches of childhood, also sometimes known as growing pains. The pain is usually non-articular, involving soft tissues rather than joints, um, almost always bilateral, happens later in the day um, or at nighttime, and usually the pain is resolved for in the morning. On a history, timing of the day, location of the day, if there's any change in walking or any disability, any fever or swelling, it's important to rule those out. On physical exam, have the child stand on their tiptoes and heels, measure leg lengths, evaluate range of motion. Is there any limp? Is there any issues with swelling, erythema, or tenderness? Diagnostic studies are not needed. Most often, reassurances are all that is necessary, but if pain is localized in one region, then an orthopedic referral would be needed. Let's talk next about limps, and those are usually mild and self-limited. Uh, can be caused from a variety of issues, most often a contusion, a sprain, or a strain. But it can be the sign of inflammatory or an infectious process, so it's important to rule that out. On table 43.5, page 913, there is a table of different types of limps. When you're assessing for this, it's important to get a good history. You want to know when the pain presented, if there's been any trauma, fevers, night sweats, weight loss, anorexia. Does it interfere with activities? On physical exam, you're going to want the child unclothed down to their underwear to observe, or even further, if you have them on the table, to observe for any erythema, swelling, atrophy, deformity. You're observing for each of the limbs, and which identify limb segments. You're going to ask the child to move around in play or running, something undistracted, to see if things are different. You're going to do a complete neuro exam, and you're also going to do the Trendelenburg sign to check for hip stability. If there's concerns past an injury, if something infectious, you might be doing CBC, SED rates, CRPs. You may be doing imaging, and if there's a serious cause, then referral. Lastly, we're going to talk about muscular dystrophies, a group of hereditary disorders of the skeletal muscle. This is a progressive degeneration of the skeletal muscle leading to weakness. They are autosomal dominant, sex-linked, and can appear in several children in a family. The X-linked dystrophies are the most common, with the most common one being Duchenne muscular dystrophy. The disease is typically seen between the ages of 3 and 6 years old. As we said, there's usually a family history of the disease. The child is not able to meet the milestones needed for motor movement, especially with independent ambulation. There may be toe walking. There can be loss of other motor skills, such as the ability to climb stairs. These kids can tire easily with physical activity. Parents may report that they have good days and bad days in relation to what they are able to accomplish. On physical exam, you may note that there is toe walking. They may have firm calf muscles. They may have a doughy feel to other muscles. They may have a wide-based stance. Lower extremities may show earlier weakness of the gluteal muscle strength. They also have a positive Gower sign, which is a classic sign found with muscular dystrophies, and it results from the weakness in the child's proximal hip muscles. And to get up from a sitting or supine position, the child must become prone on the elbows and knees, and then the knees and elbows are extended to raise the body. This is a team approach for these type of conditions. So they're going to be referred to orthopedic, metabolic, and physical therapy, social servicing, and possibly nursing care. It's important for genetic counseling um, for these families, and then patient and family support. And I believe that is the end of our power deck. Thank you for your time.